who's going to give an update on the recovery trial, which we've been quite active here in Hastings for. So our last grand round on COVID was nearly a year ago now, and quite a lot has changed in that time. Our knowledge of the virus has increased, as well as the therapeutic options available for patients. We now know a lot more about the spike protein, which is how the virus enters human cells. And it attaches via a receptor binding protein, which interacts with the ACE2 receptor in human cells and allows the virus to enter. We now know that patients for 5 days before getting clinical symptoms are potentially infectious as the virus increases in load. And a number of patients just develop mild symptoms up to day 10. And then after day 10, there's increasing inflammatory response within certain patients, and they develop severe illness such as ARDS. And throughout that time, from day 5 onwards, really, we see increased antibody production. Now, some patients, as you all know, are at increased risk of severe disease, and we now know that it's those patients over the age of 65 whose immune system isn't quite as active, and they haven't got so much memory cells that persist. Those with a high BMI and cardiovascular disease, chronic renal disease, hypertension, diabetes, and lung disease are at increased risk. And those patients who have had transplants or those who are on long-term immunosuppressants, such as rituximab, can't mount the same response as other patients despite having vaccines. So we now know that the virus is mutating, and there are different types of mutation that cause changes within the virus globally. Some mutations don't make any difference, and they've weeded out quite quickly. There are variants of interest where the virus develops an ability to transmit within a community, and then once it's able to transmit throughout the world, it becomes a virus of concern, a mutation of concern. And you can see there are numbers of different examples of mutations in the spike protein which allow it to be more transmissible. So you can see here on this screen, there was a mutation here outside the binding protein that caused the Italian outbreak, which has persisted with lots of other variants that are developed. But the UK outbreak was caused by a mutation within the spike protein in this domain, which has persisted. And the latest Delta variant also has caused a mutation here, and we'll go into that in more detail later. Now, as time has gone on, the expansion of variants throughout the world has increased, and you can see this is February 2020, and over time the increased numbers of variants throughout the world. And there are variants of interest where there's increased transmissibility within the community, and there's lots here called Kappa, Lambda, Mu, and they really are isolated within certain parts of the world at the moment. However, once they become more likely to transmit throughout the world, they become a variant of concern. And at the moment, the Delta variant is the one that we worry about the most. It's B1617. And the Alpha variant was located, first identified in the UK, and it's the B117. It hasn't so far affected vaccines so far work against Alpha, but you can see the new variants of concern are less affected by the vaccine. So we still don't have a variant of high consequence, and a variant of high consequence is one in which we can't detect. Our lateral flow tests and our PCRs don't detect it, and our vaccines and our treatment measures don't work. So at the moment, luckily, we don't have one of those. So how do we test for them? Well, we can test for the spike protein encoding mutation, or we can do genomic sequencing. However, both tests are time consuming, they take up a lot of resources, and they're difficult to do, and they're not specific. So, there's lots of benefits and risks of doing it, and most of the time we just want to know if the patient actually has the variant or not. So our knowledge of the antibody protection has also developed over time. We have always known that antibodies increase after a patient gets COVID-19, and many of the antibodies just bind and activate the complement system and allow the opsonization with the memory cells. However, neutralizing antibodies are specific. They bind to the receptor that allows it to attach to the ACE receptor. So it creates a fusion and prevents the virus entering cells. So neutralizing antibodies are the best antibodies to have. But as you can see here, the initial variant, we had higher levels of neutralizing bodies in the population to the original Wuhan virus. And now, unfortunately, as new variants come through, and the P1 is the one that's in Brazil, you can see that the amount of antibodies we have in all age groups is reduced to those new variants. So what happens when you have a vaccine? Well, this graph shows what happens to the type of symptoms that patients have before the vaccine. You can see some people get severe symptoms, a lot of people are asymptomatic, but after you vaccinate, and currently what we're seeing is we're getting more people who are asymptomatic and very, very few with severe symptoms. And this is what we're seeing with the vaccines that help reduce the severity of COVID, but don't necessarily prevent transmission. So you can still, unfortunately, transmit the virus after having the vaccine. So we don't have this situation where the vaccine is preventing transmission as well as severity of disease. And in theory, as time goes by, we'll be able to focus our vaccines on the different types of variants that are available. And currently, you've probably heard on the news that we're focusing a third dose of vaccine to those who can't manage to make an immune response to the vaccine. So unfortunately, people who are immunosuppressed, either due to cancer or on chemotherapy or primary immunodeficiencies, or those who are on rituximab or biological agents, cannot mount a response to the virus. And also when they're vaccinated, their response declines very quickly. So those are the patients who are being recommended a third dose. Now I'm going to talk a little bit about the Delta virus because that's the virus that's causing the trouble at the moment. If we hadn't had the Delta virus, we might be in a very different position, and we probably would have thought this time last year that we might be out of trouble. But the Delta virus came around and has altered everything. And the reason for this is that the spike protein, which is shown here in blue, has allowed the virus to change. So the spike protein now flexes, so that this little part of the spike protein can move, and it has allowed the virus to enter the ACE2 receptors of cells more easily. So that's a new mutation within the spike protein. And as a result, it's much more transmissible. So it's 60% more transmissible than the alpha variant. And the alpha variant is what caused the trouble to us at Christmas. So each infected person infects 8 to 9 people compared to the original strain, which was just 2. It also causes more severe disease in those who haven't had the vaccine. And unfortunately, those patients are more likely to end up in hospital. And you can see this is the spread around the world. So in December 2020, the Delta variant was just in India. By March, it had spread to the UK and out to some parts of Europe. By June, it had spread to parts of America, and it was just getting into Australia. And in August, just gone by, it spread throughout the world now, but it's predominantly in Europe. And these are the global cases of COVID throughout the world. And you can see North America, UK, and Europe are badly affected. And of those patients who've got COVID-19, the predominant type now is Delta. This graph shows the number of patients with Delta who have the infection is increasing over time, and the Alpha variant is gradually reducing. There are a number of other variants as well. The Lambda variant was seen in South American countries, and it does have higher infectivity than Alpha and Gamma, and unfortunately neutralizing antibodies don't work quite so well. There's another form called Epsilon, which was identified in California, and again has increased transmissibility, and potentially our treatments aren't as effective against it. Now, but the current rise that we're seeing worldwide is due to the Delta variant. So how is the Delta variant changing our clinical course? Well, we're seeing that the type of patients infected are different. They tend to be younger, they have less comorbidities, they deteriorate very quickly. they often have symptoms of a common cold really at the start, and they don't necessarily have loss of taste and smell. They are much higher risk of hospitalization, particularly if they haven't been vaccinated. So what do we know about the vaccines to date? Well, there are 2 mRNA vaccines, Pfizer and Moderna, and this slide shows the response of the Pfizer vaccine to reduce the incidence of COVID in patients. So this chart shows patients who've not had the vaccine compared to those who have, and those who have had the vaccine are much less likely to develop symptoms of the virus. The other types of virus of vaccine are adenovirus vector variants, and we have AstraZeneca and we have Johnson & Johnson, and these are IM, obviously, injections. The Johnson & Johnson is just 1 dose, AstraZeneca is 2 doses. But even with all these vaccines, the variants are getting through. So you can see here the original virus responded very nicely to all of the vaccines that we have available. But unfortunately, the South African variant, B1351, and the new Brazilian variant, P1, are showing some, or quite a large amount of vaccine resistance. And we're seeing lots of reduced antibody efficiency. So unfortunately, those people who are not vaccinated are much more likely to be hospitalized due to COVID-19. And unfortunately, as you all know, the people who are not vaccinated tend to be younger, and children are 1/4 of the cases currently in the US who have COVID and have not been vaccinated. But those who are vaccinated generally have less bad experience with the virus, and obviously the mortality rate is reduced dramatically. So we've talked about the variants and the different vaccines. I'm now going to talk about the clinical treatments that we have available that we didn't have last year. So when patients come into hospital, we provide oxygen therapy, and those patients who don't need oxygen therapy are generally managed in the community unless there's some social service concerns. So our recommendations are initially to start with conventional oxygen therapy, and at the same time encourage your patient to self-prone. This has lots of benefits, which we'll go on to later. If standard oxygen therapy doesn't work, high flow oxygen and then non-invasive ventilation in the form of CPAP and BiPAP are also very effective prior to intubation. Now, prone ventilation helps the patient in a number of ways. This is an ergonomic device that's designed to help people prone more easily, and as you've all seen, it is difficult for patients to manage. But it's very important because it allows the patients to recruit more easily, so you get more oxygen into the alveoli. You transmit the transpulmonary pressure more widely throughout the lung, and you improve the ventilation perfusion mismatching. So that overall, it improves right ventricular function. So it's an important thing to do. If patients are progressing despite proning and oxygen, then non-invasive ventilation in moderate to severe COVID can reduce the need to progress to intubation. And this study has recently been released, and it shows that non-invasive ventilation reduces the number of patients who need intubation compared to those who just have high flow oxygen. And if they do progress to need ventilation on intensive care, then if they are ventilated on an invasive ventilator, low tidal volume ventilation has always been the standard of care for patients with ARDS. So other treatment options obviously are available. Remdesivir has now been shown to shorten the recovery time to 4 to 5 days, but it doesn't improve mortality. Dexamethasone at 6 milligrams improves the mortality rate for those who are on 4 liters of oxygen, and that was shown by the recovery trial. And a recent Codex protocol shows that giving 20 milligrams for 5 days, followed by 10 milligrams for 5 days, for those patients on ITU with severe ARDS can improve mortality and recovery. We now have tocilizumab, which improves survival in those who are rapidly deteriorating despite dexamethasone and non-invasive ventilation. And a new form of therapy, or monotherapy, from the Regeneron study shows that you can improve the results for patients who get COVID in hospital while they're in for a different problem. So Let's look at the evidence for each of these treatments. Well, dexamethasone was shown by the recovery trial a year ago to reduce mortality in 28 days in all patients. And the recommendations now is that it should be given to all patients who need oxygen. So the standard recommendation is 4 litres of oxygen. Remdesivir works again on those patients who need supplemental oxygen, and it hastens recovery time by 3 to 5 days, but doesn't change mortality. And it's recommended in all treatment recommendations for those who are on oxygen in hospital. Tocilizumab is a recombinant humanized interleukin-6 receptor monoclonal antibody, and it works with dexamethasone to improve the results of those patients who are rapidly deteriorating despite dexamethasone, non-invasive ventilation, and high-flow oxygen. So it's recommended in those patients who are really deteriorating very quickly in hospital, and it reduces the inflammatory response. Now, monoclonal antibodies are now available in some parts of the world for patients who have mild to moderate COVID, who are not in hospital, so those patients who are not needing oxygen. And there were 3 studies that were looked at these. The first 2 were created by Eli Ellie, and the second one was conducted by Regeneron. And the monoclonal antibodies work by blocking the interaction between the receptor binding protein and the ACE protein. So there were 3 or 4 actually available. The first one, bamlanivimab, was revoked, unfortunately, in April due to the reduced effectiveness of this monoclonal antibody against the Delta variant. However, casomivimab and imdevimab are a very effective combination which are recommended now, and we'll go on to talk about those. In these studies, they recruited patients with mild to moderate COVID. All of the patients weighed more than 40 kilograms, and they had a positive PCR test, and most importantly, they had a high risk of progression. And they infused the monoclonal antibodies within 10 days of the patient getting symptomatic onset. Now, the exclusion criteria were the patients who were already in hospital with COVID, so quite severe COVID, or those who were in the community with on oxygen due to another cause. And the inclusion criteria has increased over time. Initially, they said they only wanted patients who were over the age of 65 or those at high risk of progressing, so those with cardiovascular disease, hypertension or COPD, a BMI greater than 35, chronic renal disease or diabetes, or those on immunosuppressant agents. However, over time, they've increased this criteria. So now you can see in some parts of the world, they recommend giving these monoclonal antibodies to people in the community who are potentially pregnant, very overweight, those on immunosuppressant medications, and then all those poor patients who've got chronic lung disease, so our COPDs, asthmas, those with pulmonary hypertension, and those with other conditions that put them at increased risk. But as unfortunately with the vaccines and our other therapies, the variants are stopping the effectiveness of this monoclonal antibody. And you can see that bamlanivimab, unfortunately, the effectiveness of the monoclonal antibody was reduced over time. So nowadays, the recommendations are only to use the combination casomivimab and imdevimab for patients, because that doesn't alter depending on the variant. And in parts of the world where we're using these monoclonal antibodies, we use a mass score to determine the risk of progression, so to find out which patient should benefit from these. And they give a score according to the patient's age, whether they have cardiovascular disease, and whether they have other conditions such as chronic renal disease, diabetes, or immunosuppressant agents. And this study, you can see, shows that the combination of casomivimab and imdevimab reduces the results of the risk of hospitalization in those patients with mild to moderate COVID in the community. In this slide, you can see that those patients who accepted the monoclonal antibody tended to do better than those patients who declined it. So the ones in dark grey are the ones that accepted it. And as you go up, you can see these ones had a very low MAS score, so they had a low risk of progression, whereas those with a score of 5 had lots of comorbidities and high rate of progression. And you can see those that accepted the monoclonal antibody had reduced risk of hospitalization compared to those who declined the monoclonal antibody. So it clearly has an effect. If you look at the adverse reactions to these monoclonal antibodies, they're very minimal. Very few people had any reaction, and most of it was quite mild. Fever seems to be the main symptom they got, and none of them had anaphylaxis. So in parts of the world where it's being used, they tend to identify patients quite early. They recommend the infusion of the treatment to them, and if they consent, then they are given an appointment to come up to the hospital or the delivery centre where it's provided. And these are some examples of sites where these monoclonal antibodies are given. And you can see they tend to be outside the hospital. This one is in a van outside the hospital. So the nurse puts her PPE on in this tent, and the patients have their treatment in the van, and then they go to another tent where they have their 30 minutes of observation afterwards to look for any side effects. Obviously, the staff wear full PPE, and it's all conducted outside the hospital to reduce transmission to patients who might be at risk within the hospital. So you can see it's quite an effective therapy, and it's obviously being used in some parts of the world. Let's see if we can move on. Right, so I've gone through a little bit about what treatments now are available, and we're going to finalise with how do we end the pandemic. Well, unfortunately, as you can see, the variants are very clever. They're getting around our treatment strategies and our vaccines. So the only way we can end the pandemic is for everyone to be vaccinated. And unfortunately, other things like wearing masks and using social distancing are still important. And the variants will continue to evolve, and some might develop an ability to evade our vaccine-induced and convalescent immunity. And as we see more people being unvaccinated, increased transmission in the variants, complacency of using masks and social distancing, and seasonality as the UV light reduces in the winter months and children go back to school and universities, and we increase worldwide travel, we're likely to see more waves. And this time last year, we had very little flu in the hospital, and that's because we were using masks and social distancing. There is a risk this year that as we reduce social distancing and we don't use masks so much, we might see more flu as well as COVID. And that will potentially be a twindemic. Right, so I'm going to hand over to Dr. Kankam now, if he's available. Let's see. Are you there, Dr. Kankam?
Yes, I'm here.
Fantastic. Right, so I'm going to share I'm going to stop sharing now. And do you want to try sharing your content?
Okay. Just a minute, please. I'm just.
While also setting up, I just want to say thanks a lot for that, Teresa. That was a really fantastic overview, really helpful.
Do you have any while we're so it looks like he's nearly ready. I can see your slides, Osai.
Yeah. Okay.
Okay, maybe we'll leave the questions to the end then. Let's do let Dr. Kankam do his presentation.
Yeah, I have a few slides. It's just to buttress what you said about the recovery trial. So the recovery trial, we got involved in the recovery trial in April, March last year. Recovery stands for randomized evaluation of COVID-19 therapy. So that's recovery. There were two arms to the trial. One was for therapy, which is the first one, and the second one was a recovery RS trial. Now, ESHT have recruited patients into both of them. The majority have gone into the therapy trial. The RS trial for respiratory support, and it was published about 3 weeks ago, and it shows that CPAP therapy is effective over high flow nasal oxygen or conventional oxygen therapy in patients with respiratory failure when their saturations are less than 94% and having an FiO2 inspired oxygen of more than 40%. And on the clinician's judgment needs escalation, then in all these arms, if you give CPAP therapy, is effective. So that buttresses the rationale for the use of CPAP therapy in patients with respiratory failure as a result of COVID. As I said, ESHT has recruited more than 130 patients. I'm the co-principal investigator for the trust, and so Dr. Marshall is the main principal investigator. Now, about the recovery trial, this is a trial slide from the website, our recovery website, and it just shows what it's been done in the last 2 years. It has investigated hydroxychloroquine, lopinavir, and loratadine, which were antiviral medications, azithromycin, and even convalescent serum. And we tried all these medications, and obviously the evidence tells us that it makes no difference to outcome, and it does not reduce the risk of death. But it found that dexamethasone significantly reduced the risk of death. And it's interesting because at the beginning of COVID, we were concerned that those on steroids were not going to do well because of immunosuppression. But interestingly, now dexamethasone is the lifesaver. And another aside is that we were expecting a lot of asthmatic admissions, but didn't have a lot of them. And there's some postulation that inhaled budesonide
Oh, sorry, we've lost your voice. Can you check your microphone?
I'm sorry. I think. Can you hear me? Somebody? I think I froze.
I can see you,
yeah. Okay. So, so we did all these medications, and we found that dexamethasone reduces the risk of death among patients. And so, and then the other thing I haven't mentioned here is Regeneron, which was part of the trial treatment. And as Dr. Christopherson said, apart from the other trials, recovery also looked at Regeneron, which has now been approved for use in the UK. Unfortunately, there is none available in the supply chain at the moment. Children and pregnant women have specific recruitment pathways. This is the current pathway we use. So once you randomize a patient into the system, it's a very simple randomization process. We consent the patient, we get all the information from research and the NHS and their results. We enter the information in there, and it gives us a choice of 3 to 4 pathways. So dimethyl fumarate, which we are not using at the moment, which is used in inflammatory disorders. It gives you the choice between the use of high-dose corticosteroids, which is higher than the 6 milligram of dexamethasone, or baricitinib, which is an anti-inflammatory agent used in rheumatoid arthritis. And the latest one is the use of empagliflozin, which is a diabetes SGLT1 medication. It's believed that the virus probably thrives on glucose, and so if you get rid of circulating glucose in the bloodstream, it probably have less substrate to multiplying, and that may help outcome, but that is used for a total of 28 days. So all in all, we would, based on the evidence base, we will give patients dexamethasone, remdesivir when it's needed, tocilizumab when it's needed, and then randomize them into this trial. If they are not usual care, then they have a choice of 2 or 3 other medications. So it's ongoing, and it will certainly inform how well we can treat our patients going forward. If you're interested in recruiting, this is a straightforward website. It gives you about 15-30 slides to go through. No, about 20 slides to go through. And then once you've done that, you get your certificate of training. And then you forward it to the recruitment, the research department, or to me, and then I can help you recruit your next patient. I think I would end here, and we'll be happy to take questions on the recovery trial. Thank you.
Okay,
Therese, also, thank you so much. Those are fantastic talks about it. I think the floor is open to any questions from the group. I definitely have a few, but it would be good to see who's got their hands up. Dr. McIntyre's got his hands up. Hugh, please go ahead.
Thanks both of you. But question to Dre and it's a kind of physiology question actually. You in passing, when you were talking about proning, you said the value of putting them on the front was you reduced ventilatory perfusionary mismatch, and thereby took the load off the right ventricle. Now, I'd kind of not really thought about hypoxia. Is that actually what you're trying to do with hypoxia, and is that actually what kills these people then? Because I'd sort of thought low oxygen brain. I hadn't really thought it through. Is it RV dysfunction?
Yeah.
Okay.
So if you think about the lungs, the lungs are like a sponge under the sea. You get in the coral reef, and if you have the virus in it and you're very overweight and you're sitting on it, you can imagine that sponge is very squashed. And all that CPAP does and proning is that it fills up those little alveoli and it holds them open. So when you turn the patient over, they go from squashed lung to opened lung.
No, I get that, but the goal of all of that is in a way to protect the RV.
Yeah, it does, because the lower the oxygen levels are, the more risk you have of right ventricular dysfunction, and that's what pulmonary hypertension is ultimately, isn't it?
No, I understand that. In the acute phase, how does the RV play into physiological decline?
So again, it's pressure on the right ventricle due to hypoxia. The pulmonary artery pressures go up as hypoxia progresses.
But is it therefore
on the right ventricle?
But is it that they don't fill the left ventricle and therefore their blood pressure drops? I mean,
so as you get more hypoxic, your pulmonary arteries constrict.
No, I understand that, but I'm trying to then what?
So as the pressures go up, it backs up onto the right ventricle, and you get right ventricular dysfunction. But it happens over time, and the quicker you can reverse that by improving oxygenation, the less impact it has. And particularly if you think of poor patients on ITU, for the first wave, were there for 3 months. So the more impact, a lot of them ended up with right ventricular dysfunction, and you can avoid that by doing prone ventilation.
To be sure, there's a lot more about COVID physiology that's left to be understood, isn't there? Thanks for the question, Hugh. Agnes, Dr. Hertz has got a question too. Go ahead, Agnes.
Thanks. I was just wondering, do you think with the prone ventilation that there's also a sort of mechanical advantage from freeing up the diaphragm, because a lot of these changes are peripheral? So whether you get better volume of distribution.
Yeah. The trouble is that a lot of our patients are very overweight, aren't they? And their diaphragm's pushed up because of their weight. Proning helps to a certain extent, but as you've all seen in practice, it's very hard to prone in overweight patients. And that device I showed you was illustrated at the ERS. They tried to show that they had made this device to make it easier, but actually you could just use some big bags of saline, pillows, the same response would happen. But it's all to help push the diaphragm down to get better ventilation and optimize oxygenation.
And I just wanted to ask one more thing. What sort of data is out there for improving diabetic control for outcomes overall in all the COVID sort of cohort?
So I haven't seen much published. Have you, Dr. Kankam? I haven't seen an awful lot on that. I think it's a very important question because we all see it, especially after giving them dexamethasone. The guidelines now, you shouldn't give dexamethasone unless people are on at least 4 litres of oxygen for that reason, because it does have an impact. Have you seen any, Dr. Kankam, on diabetes?
Not specifically. I've seen guidelines on how to manage the steroid-induced hyperglycemia. Initially, it was from St. Thomas's, but now the Diabetic Association has a guideline which we all follow. I think your specific question, is it related to the treatment of hyperglycemia related to steroid use per se, or is it management of diabetes in people who have COVID?
Yeah, it's overall diabetic control, because most of the critical illnesses, severe illnesses, have a better outcome, sort of secondary measures over and above survival, when you control for diabetes, like sepsis, pneumonia, etc. And I was just wondering if there was something specific to COVID as well, considering that they use sodium glucose transporters now in the recovery trial?
I think the theory behind that is I said they believe that virus substrate is glucose, and so if you deprive them of glucose, then they will multiply. That seems to be a very simplistic physiological reason. And they also talk about the lipid metabolism, which would also impair viral replication. So that's their theory in which they are doing it. So I presume that even if you are not diabetic now, sodium glucose transporters are used for people who've had failure without any diabetes, without glycemic problems at all. And the final thing is that it has an inherent anti-inflammatory property. So probably, quite apart from improving glycemic control and not going into high blood sugars, there is something about lipid metabolism and also reducing inflammation in general. So maybe that is what we will find.
Yeah, I think it probably will be pro-inflammatory, and then also the co-transporter, the natriuresis property of it, you know, sort of avoiding corpuscular and that kind of thing in that setting.
So maybe that's it. But going back to your question, prior to the use of dexamethasone as a standard form of treatment, we didn't see a lot of hyperglycemic control problems in the people who were admitted with diabetes, interestingly. Unfortunately, now we use dexamethasone more, as you will see. Every diabetic who comes in, we struggle to get them out of hospital because we treat the respiratory failure and then we have to treat the glycemic problems.
So thanks. Neil Sharma's got a question.
Yeah, hi. Thanks for that great presentation. I just had a quick question. I wanted to ask Teresa, with some of the epidemiology stuff you mentioned at the beginning, now that PCRs are sort of stopping or being greatly reduced with international flights, they're all being lateral flows, there's sort of a perceived risk that genomic sequencing will be reduced. And instead of being ahead of the virus mutations, we can sort of slip behind. Do you think that's a real risk, or do you think this is not that important?
So I think it depends on if we get another variant like Delta. So a variant of extreme concern would be one that we can't identify and that we can't treat. So if we don't test for it, we can't see it. And that's what's the worry. You know, it's always the same in medicine. If you look for something, you can find it and treat it. But if you can't see it, it's much harder. So I think that's what I'm worried about the most, particularly as we see more flu. So it might be more unclear what's wrong with the patient. If we're not testing for PCR, then we won't know if it's COVID, if it's flu, if it's another type of RSV virus. And there is a risk of, as the transmission goes up, you know, we're going to spread it more easily. And the less people are vaccinated, the more problems we're going to get with that. So I think we're in for an interesting time. And I'm surprised that, like you, that we're not testing for the variant more, because as international travel goes up, well, of course, we're going to see more transmission around the world. Yeah. And a variant of interest becomes an variant of concern if you get global transmission, and that's exactly what we're going to see now.
Yeah, no, I agree. Yeah, thank you very much. Really good presentation.
Interestingly, just to put a down on this, actually, currently, it's less than 5% of the PCR tests are sent for genomic sequencing. Because if it's performed in an NHS lab, then it's about 12% are, but the private labs don't send most of their samples to PHE for genomic sequencing. So there are probably other variants of concern circulating that we haven't identified.
Steve, could I just come back on that point about variants? I thought there was a line of thought that said equally, COVID might just burn itself out in the same way as things like flu epidemics burn themselves out, like the 1918 one. I mean, this, I suppose, strays into herd immunity territory. But I mean, is there any reason to think to see COVID as different from any other serious viral outbreak in history, which tend to be self-limiting? Is there any reason to see it's different?
So the only thing we have to worry about is a variant like Delta, because it mutated within the receptor binding domain to make it more flexible, so it's much easier for it to transmit. And we don't know if we're going to get another one. That's the problem. If we don't get another one, then it'll burn out just like alpha did. On that chart, you can see alpha is declining quite rapidly because it can't transmit. It hasn't got the ability to flex on the receptor binding domain like delta can. And we just don't know what's going to happen next. But the more people who are unvaccinated and the more travel we have and the less social distancing we do, the more likely we are to see another variant. But we just don't know what's going to happen. And that's why the recommendations around the world are you should try and continue to wear masks, social distance, and vaccinate everyone, not just a few, to get rid of the virus quickly.
Thanks, Therese. So, Therese, also, I've got a few questions thinking with my junior doctor cap on, things that as junior doctors we kind of want to know. One of the questions I think we get from our new batch, because obviously everyone starts in August, is what is treat as positive? Is that mean the same thing as it did 6 months ago? Or do we feel like we're getting complacent with being vigilant?
I think we have to remain vigilant because remember, the patients in hospital are immunocompromised. Their vaccine won't be working quite so well. So if you think someone's coming in, they're rapidly deteriorating, they're lymphopenic, their x-rays changing quickly, and you can't exclude and you can't find another cause, I think it's sensible to put them in a side room and wear PPE because we need to do PCR on these patients. And you know, if their PCR is coming back negative, you have to worry that we're getting a different type of variant that's evading our PCR ability to diagnose it. So the safest thing is put them in a side room and give them treatment that might work for COVID. I think you can't do any harm that way. The harm happens if you leave them on an open ward with patients who don't have the same immunity, people who are transplant patients or those who are on biological agents. I think we just need, as doctors, we need to be aware and try and prevent problems or reduce the risk as much as possible.
Thank you. The second question they're asking is the level of prescribing of drugs, as a junior doctor, should all of them be comfortable with prescribing dexamethasone as the front line? Who makes a decision about prescribing slightly more advanced drugs like remdesivir and all that? So it's I guess a question, because this is something we had before where SHOs during the first pandemic were saying, should I be the one prescribing remdesivir or do I have to ask someone? So where do we stand with that now if you were a medical SHO on the front line with a case?
So I think we've discussed today at the ground round that some treatments are recommended now. They're not trials anymore. Dr. Kankam talked about the recovery trial, but it's now recommended. In my presentation, I showed that it's now recommended treatment for people who are on at least 4 litres of oxygen to maintain SATs of 94%. So anyone can prescribe that. And remember, the earlier you give it, the more impact it's going to have. So you shouldn't wait for the consultant. If you really think it's COVID and you've got evidence, then you should treat. Again, with remdesivir, look for the contraindications. If you can't see any, the LFTs are normal, it's not going to interact. You can prescribe it. Pharmacy will always check. They won't give it unless they're happy. And generally, they ask for a consultant to check beforehand before it's actually delivered to the patient. But you can always prescribe, and pharmacy will contact one of the consultants. And then with tocilizumab, again, the risk is, you see, if a patient comes in on a Friday night and you give them dexamethasone and by Saturday morning they're suddenly on CPAP deteriorating really quickly, it's a shame to not give them tocilizumab, because that is recommended now to be effective for people who are deteriorating rapidly. It's been shown in multiple trials to be effective. So I think you can always prescribe, discuss it with a senior consultant, with a registrar or consultant on call, and it gives pharmacy then a bit of time to get ahead. Remember, these drugs take time to get from pharmacy. I think you can always prescribe it and discuss it with a senior, and then pharmacy have more chance of giving it within a time frame that's going to be effective. It'd be awfully if we just left it till Monday and the poor patient doesn't get the benefit then. Unfortunately, with the monoclonal antibodies, we don't have access to them yet, so they're not available to us.
Last question from a junior doctor's perspective. So if I've got someone with sleep apnea in a, well, I guess a green ward, and they're in a bay, but they normally have their CPAP overnight, can I start it?
So it is an aerosolizing procedure. That's the problem. And our recommendations are that CPAP should have a viral filter attached. It should be a full face mask. It shouldn't be one of the ones that they have at home, because the exhalation port on the ones they have at home is in the face mask. So as they breathe in and out, it'll shoot all over the room. So our recommendations are that it should be in a side room on the respiratory ward with full PPE and with the viral filter. And if they don't need it, a lot of people with OSA, they don't have to have their CPAP every night. If they're only going to stay in for 1 or 2 nights, for example, if they're coming in with cellulitis, they don't necessarily need to stay in hospital. They might be able to go home the next day or 1 or 2 days later and start their CPAP at home. So I'd recommend you contact the respiratory team, and we'll give you advice of, whether they can leave it off for a day or so, or whether they need to come to a side room to have it.
Thank you, Teresa. And that's it from me. And Neil's put on the ASH, the acute respiratory care pathway for COVID, which I think that will be really helpful for juniors. Thanks for that, Neil. That's it from me. But has anyone else got any questions from the audience? Because I thought this has been really helpful, really up to date for most of us who've dealt with COVID, but probably haven't had something recent to keep us up to date with the latest developments.
Yeah, one question that patients might ask you is, if they've had their virus, when should they have the vaccine? Does anyone know the answer to that? So it's 90 days, generally 90 days. And some people say, if they've had the virus, is that as good as having the vaccine? And it's not. So the antibodies you get after having the virus don't last as long. Unfortunately, the vaccination creates more response that lasts longer.
Sorry, Trace, is that with regard to the booster then you're talking about, or just vaccination full stop?
So vaccination full stop has a bigger impact. So if you've never had the virus and you have the vaccine, you're supposed to get an 18-fold increase in antibodies that over time obviously develop, and then they wane over time. If you've had the virus and then you have the vaccine, apparently that number increases to 30,000. So just having the virus isn't a reason not to have the vaccine. You should encourage your patients, if they've had the virus, they should still have the vaccine, because it will boost their immunity even more. And they've recently studied healthcare workers in America, and they found that those healthcare workers, after having vaccine, had lots of T-cell response as well. So it's not just one form of immunity that you get long-lived immunity. And boosters, unfortunately, are needed for those poor patients who've had transplants or on immunosuppressants like rituximab, who just can't maintain that response. So they need those boosters.
Yes, I think that's the problem we are seeing in our gastro side of things, is a lot of our patients are immunosuppressive drugs, biologics for Crohn's and colitis. We are sending out a lot of letters to ask them to have their 3rd dose, which is apparently not the same as the booster. I think there's the dilemma. What if you've been on infliximab or biologic, got a COVID infection? When do you have your dose? Slightly tricky ones, actually.
Yeah,
so
that's hard to know, yeah.
Sorry, also here to add to that, the one thing we'd have to consider is there's some group of patients who would have had double dose vaccines and have mounted no antibody response at all. And some of the things we'd have to contend with in future is to see whether, for some of these patients, we check their antibody levels and consider giving them MABs when we think they are most vulnerable at the early stages of infection. I have a patient now who has CLL, has had 2 doses of Pfizer vaccination, has come in with acute COVID pneumonitis and with respiratory failure, but has no antibodies at all, either to the either to the vaccine or to the acute infection. So he's a candidate where I can give him the MAB. Unfortunately, even though it's licensed for use in the UK, it's not physically available. So we've sent a request for him to have one. So it is something we may have to contend with, and consider the use of antibodies for your group of patients.
And especially if they get COVID in hospital. In America, they give those monoclonal antibodies to people who get COVID in hospital to try and prevent them getting sick. So it's a shame we don't have it here. But it means that we need to work harder. If a patient comes in with those risk factors, we should really make sure that they're, you know, protected as much as we can from patients with flu-like illnesses and COVID.
Definitely. Well, I think I don't see any more questions in the group, but I just wanted to thank Teresa and Osai for the brilliant presentations. I'm sure this is not the end of it. I'm sure we'll need another update in a few months' time, come early 2022, to see what new surprises COVID has in store for us. But I want to thank everyone who's attended today. I hope it was helpful. And thank you so much for the presentations, Teresa and Osai.
You're welcome.
Really grateful.
Okay, take care. Bye-bye then.